Support for this episode comes from Dexcom. Like most of you, we don't love worrying about insurance. I'm thrilled to tell you that Dexcom CGM is covered as a medical benefit for 98% of commercial insurance plan holders who have type 1 diabetes. And more plans cover CGM for people with type 2 who use insulin. We even have it as a pharmacy benefit, so I can process it at the local pharmacy. They put it on auto refill for me, which makes it really easy. It's one less thing to think about. It's worth checking to see if that's available to you. And Dexcom will even help you do a benefits check to see what your insurance covers. It's easy. It's right on the website. Dexcom is the #1 covered CGM brand. Learn more, go to diabetes-connections.com and click on the Dexcom logo.
This is Diabetes Connections with Stacey Sims.
This week, we've been hearing a lot more about screening for type 1 diabetes. I saw my first mainstream commercial about it just a couple of days ago. But what does it all mean? If you have type 1 or if you have a child with T1D, are you thinking about screening other family members? Should you? Over the summer, new guidelines were announced for healthcare providers, including mental health guidelines. There's a lot to unpack here. My guest is the Director of Community Screening and Clinical Trials Education with Breakthrough T1D. This podcast is not intended as medical advice. If you have those kinds of questions, please contact your healthcare provider. Welcome, everybody, to another week of the show. I am always so glad to have you here. You know we aim to educate and inspire about diabetes with a focus on people who use insulin. I'm your host, Stacey Sims. And if you are new around here, my son Benny was diagnosed with type 1 back in 2006, just before he turned 2. He is now 19 and a sophomore in college. My husband has type 2 diabetes. I don't have any diabetes. I have a background in broadcasting, and that's why I started the podcast back in 2015. So screening, we've talked about that a lot around here over the years, but it's really changed, right? I mean, it used to be that there wasn't really anything tangible you could do. So you might get screened through TrialNet, maybe at your kid's camp or at a JDRF conference. I mean, I know that information was used in research, so I shouldn't say there's nothing tangible that happened. But once Tzield was approved, some families could at least take some action. And there is a lot more to come. I mentioned that I saw my first mainstream commercial, and by that I mean, not on YouTube, not on social media, not targeted at me as a diabetes person. I mean a random viewing of a commercial on a TV set that I did not set the channel. I was actually in my eye doctor's office, and the Sanofi screening commercial came on, and it was just really interesting to see. By the way, quick dumb story about my eye. I had a great trip in early September with my sister. We went to Montreal, did a ton of sightseeing, just had a fantastic time. But I can't believe I did this. I have my glasses on top of my head all the time. I need reading glasses. I sometimes need regular glasses. I have bifocals. I don't like wearing them all the time. I'm constantly flipping my glasses up and down. And I had a pair of glasses on top of my head. They were starting to fall backwards. So I reached up really quickly to grab them, and I scratched my eyelid. I mean, how do you even do that? I just bunked myself right in the eye. It didn't really hurt that badly. I could tell that I scratched the skin a tiny little bit. Everything seemed fine. But the next morning I woke up with a bunch of floaters in that eye. And I actually have a history of this. I won't go into a very long story here, but when I was pregnant with Benny, I'm extremely nearsighted, and that can increase your risk of a retinal detachment. So I did have some issues at that time. And so every couple of years, I have to get a very intense eye exam. And if you're listening with diabetes, you know what I'm talking about. So the floaters really made me a little nervous. They did improve day by day, which was great. And then when I got home, I went to the eye doctor, and she said everything was fine. I think in her words, she said I had shaken things up a bit, but the eyelid's fine. The eye itself is fine. And that is how I found myself in the waiting room seeing the type 1 diabetes screening commercial. Okay, my guest this week is Anastasia Albanese-O'Neill, Director of Community Screening and Clinical Trials Education with Breakthrough T1D, formerly JDRF. And as you'll hear, her daughter was diagnosed in 2002, and Anastasia transitioned to a career in diabetes education and research a few years later. This summer, Breakthrough T1D led an effort to develop the first internationally agreed upon guidance for anyone who tests positive for T1D autoantibodies. And I will link all of that up in the show notes. our conversation about the guidelines, what they mean for the diabetes community, and for the general population right after this. Now that Benny is on his own more and more, I'm grateful that he's open about his diabetes journey and always tells his friends how to use his emergency glucagon, Gvoke HypoPen. Gvoke HypoPen is a ready-to-use rescue pen for treating very low blood sugar in people with diabetes ages 2 and above. If you take insulin or sulfonylureas, you are at risk for your blood sugar going too low. Low blood sugar emergencies can happen unexpectedly, and they demand quick action. You need a safety net when it matters most. Be ready to treat a very low blood sugar with Gvoke HypoPen. Find out more, go to gvokeglucagon.com/Stacy. That's gvokeglucagon.com/STACEY. Gvoke should not be used if you have a tumor in the gland on top of your kidneys called pheochromocytoma, or if you have a tumor in your pancreas called insulinoma. Visit gvokeglucagon.com/risk for safety information. Anastasia, welcome. Thanks so much for sharing some time with me and my listeners on a topic that I feel like, you all have certainly been working on for a long time, but that is so new to so many of us. Thanks for being here.
Thank you. Thank you for inviting me. And you're right, we've got to get the word out. So thank you so much for this opportunity to be here with you today.
Would you mind starting by talking about kind of what your position is? What do you do? Why do we need somebody in that role?
Yeah, so I didn't think of my position. Then JDRF advertised it and I threw my hat in the ring. And I was particularly interested and mainly by the things that drive me as a parent of a child with type 1 diabetes. This was an opportunity to get engaged in work that is really at the cutting edge of clinical care in type 1 diabetes. When our daughter was diagnosed with type 1, we had a blood glucose meter and we had a syringe we could fill it with NPH or regular insulin. Wow. Fast forward to today, we have an FDA-approved therapy that delays the onset of type 1 diabetes, an FDA-approved therapy, let me say that again, that delays the onset of type 1 diabetes by 2 to 3 years. We have, last week it was 6 clinical trials, now it's 5, only because one of them filled and closed. We have 5 now clinical trials that are recruiting right now, and they are aimed at delaying and preventing type 1 diabetes. And we also know that we can prevent DKA at diagnosis if more people get screened. So what is my job? And now I have a team. So it's not just me. When I started, it was just me in this role. Now there's 4 of us. But our goal really is to educate about this new and changing clinical paradigm in type 1 diabetes. It's not just about monitoring glucose and administering insulin. In the future, it's going to look different. And that is really exciting. And I'm here because I wanted to be a part of that and sort of leverage my background in healthcare and also, frankly, as a parent, to really spread the news. That's what our team does. We talk about the importance of early detection. We talk about the importance of clinical trial participation. And we try to educate everybody in the ecosystem, from healthcare professionals all the way to somebody who was diagnosed yesterday, and also people who maybe should consider screening but haven't yet thought about it.
Yeah. Well, and that leads us to the next part of this. Can you talk a little bit about, we're going to talk about the consensus guidelines around screening, because that's something that was new. Very important. But before we talk about the consensus guidelines, can you talk about why they're needed? You've already mentioned, things have changed so much in the last couple of years.
Yeah. So to do this, Stacy, we need to step a little bit into the way back machine and go back to the 1980s. Let me say that again, when we started to screen people for type 1 diabetes autoantibodies. What are autoantibodies? They are a marker in the blood that tells us that the human immune system is attacking the insulin-producing cells in the pancreas and destroying them. Breakthrough T1D has been funding that research for decades. And as the 80s went forward and the 90s and the 2000s, we eventually got to a point in 2015 when we described what is now called early stage type 1 diabetes. And that means that you have these autoantibodies, they've been confirmed as persistent, and you are progressing to what is now known as stage 3 type 1 diabetes, which means that you require insulin. Before 2015, nobody had described that early staging, and we didn't have enough evidence to confidently identify people who were in that early stage. What do we know now? What we know now is people who are in early stage. So stage 1 is you've got 2 or more of these persistent autoantibodies. You don't just test once, you've got to get them confirmed. But we've got 2 or more of these autoantibodies. You don't have any symptoms. Your blood sugars are completely normal, but you're on the path. You're on the path to stage 3. Then, as more of those insulin-producing cells are destroyed, we get what you call dysglycemia, or abnormal blood glucose levels, usually after big meals with a lot of carbs because your body can't respond with enough insulin. And then eventually we get to a diagnosis where insulin is required. But the important thing here, Stacey, is three things. One is during all of that autoantibody screening, all that research, what do we learn? We learned that we can prevent or reduce the risk of DKA at diagnosis all the way down to less than 5% in studies that have been replicated in Australia, in Europe, and in the United States. So number one, clear clinical benefit. Two, we got a lot of research that's recruiting right now. And three, we've got an approved therapy, but nobody knows this existed. When I went to nursing school, this was not taught in my advanced pathophysiology class. So we got to get the word out.
Wow. Lot to take in there.
Sorry.
No, you're great.
You asked me a question.
I love it. This is going to be fun.
Yeah.
I did want to just jump in with, as you listen, we have done a few episodes. Well, we've done a lot of episodes from the beginning of this podcast back in 2015 on teplizumab, which became Tzield. And we've talked to at least one family that has benefited. So as you listen, if you want to kind of get on the ground, how does this work? What does this mean for a particular family? I will link that episode up in the show notes. But Anastasia, when we're talking about the consensus guidelines now, what do they say? Like, what changes because of, I guess, this paper or this guideline?
No, that's a great question. So I have been personally interested in screening for a long time. My son, who doesn't have type 1, participated in a screening study. I've participated. So has my husband, other family members. We think screening is the key to understanding why human type 1 diabetes happens and then better understanding how to delay and prevent it. And because of all the people who participated in that research, we get to approved therapies like teplizumab. But what didn't exist, Stacey, what didn't exist in the clinical guidance is a clear plan of care for people who participated in that research or screened through another avenue and came back with those positive autoantibodies. So I had the privilege of training at the University of Florida under one of my favorite pediatric endocrinologists, Desmond Schatz. And when I was growing up to be a pediatric nurse practitioner, I would bring a complex clinical question into the clinic conference room, and he'd say, well, Anastasia, if you're going to order those labs, what are you going to do with the result? And this was a challenge for the type 1 diabetes community in early stage type 1 diabetes. We had people out there, literally hundreds of thousands of people have participated in screening around the world. People were out there walking around with positive autoantibodies, and their PCPs, their primary care healthcare provider, and in some cases, maybe their specialty care provider didn't have clear guidance on what to do, how often to monitor their autoantibodies, how often to monitor their blood sugar, what other tests they should be doing, what education they should be providing. So we think this document answers that question. If I order this lab, what do I do with the result, and what is my plan of care when that result comes back positive?
Yeah. And I think that's such an important point because we've talked about this anecdotally. I'm certainly not a healthcare professional, but I know a lot of people who've been screened, whether it was TrialNet or other kinds of early screening programs. And the question was, well, if you get a positive result, what are you going to do with it? To the point where, as you know, and I'm sure we will talk about, many people avoid screening altogether because they didn't know what they would personally do with the results. And if your doctor doesn't even know what to do with the results, it can be very scary and overwhelming.
That's exactly right. I think this expertise was the reason we got to the consensus on the guidance, because the good news is there was a lot of expertise out there. And what was super exciting was to see the genuine enthusiasm. Globally, we had people from 4 continents represented on this guidance. They see the enthusiasm to look at the evidence, to put the best possible recommendations forward, to grade that evidence, and then to make it available globally. This was endorsed by all sorts of diabetes organizations around the world. So it really does summarize what we know right now, and it allows people to put actionable plans of care in place in a variety of healthcare settings, which is super exciting. So we tried to really, I guess, eliminate that barrier that you highlighted and also put into place this foundational block for the opportunity to invite more people to participate in screening.
We cannot audibly go through all of the screening guidelines. It's not practical. They're long. There's a lot of doctor speak, I am sure. What should people in the diabetes community, though, know? And certainly they can go look at these, but what should we know kind of high level?
People need to know 2 things. First, they need to know and consider the benefits of screening for type 1 diabetes autoantibodies, and as that relates to early detection. When you and I were talking about the staging criteria, what we know is when somebody has persistent confirmed type 1 diabetes autoantibodies, their likelihood of progressing to requiring insulin in stage 3 is approaching 100%. So that's why when somebody does come back positive and those autoantibodies are confirmed, we want to make sure we've got an appropriate plan of care. What people also need to know on a very hopeful level, what they need to know again, on a very hopeful note, is that there are things that we can do that are important. The first is screening has been shown to have a significant impact on reducing DKA at diagnosis. You asked what I do at Breakthrough T1D and why I do it. My daughter was diagnosed in DKA. I would never wish that on another family. I think it's really important that people know that there is a direct clinical benefit to be realized if people participate in screening and monitoring, because we can see it coming. That's number one. Number two, we support research at Breakthrough T1D, and so does the National Institutes of Health and other partners around the globe. We want to get to prevention and delay. So there are studies recruiting right now that need to fill. The teplizumab study took 10 years. 10 years, Stacey. We don't want studies to take 10 years to complete. And often they're slowed down because people aren't aware of them. And for studies aimed at delaying and preventing type 1 diabetes, we need people to be screened so we can catch them before they require insulin and invite them to participate. And then finally, we have an approved therapy. So that summarizes really the benefits of screening. To that, I would add time to plan and prepare. And it's not just to prepare to think about what am I going to do next, but it's also time to plan and prepare to think about, should I engage in research now in an early stage of type 1 diabetes? Or is it my preference to wait and do a study at a stage 3 diagnosis when insulin is required? Some people may make that choice. The key there, though, is a lot of those studies only give you 100 days to make that decision. Mm-hmm. Back when my daughter was diagnosed and we were in the ICU, there was no way I could have made any decision within 100 days. I was really just trying to keep my head above water. So time to plan and prepare has a lot of nuance to it. And we hope, again, that people will consider research to help us reach our mission of a world without type 1 diabetes.
When you mentioned DKA a couple times here, I think it's worth noting, and please correct me if I'm wrong, but I thought I read that in the US, the rate of diagnosis, I'm going to say this the wrong way, but something like 40%, 45% of new cases of type 1 diabetes are diagnosed while the person is in DKA. Is that correct? Something like that?
Yeah, no, Stacey, you're right. The best data we have is for children and adolescents, as usual. But so we need more data on adults. But what we know is it varies by state, but somewhere between 25 and approaching 50% of people at diagnosis experience DKA. And that number is unacceptable. We've got to use all the tools in our toolkit to do better. And this is one of them.
Let me throw some stuff at you that I hear all the time. And some of it's from me. I'm thrilled we have Tzield. I'm thrilled we're doing more screening. I have, obviously, a child with type 1 diabetes. He's 19. I have an older child. She's 3 years older, not diagnosed. We never had her screened. When she was a kid, I did it mostly because I didn't want another needle for her. I didn't want to go through all that. And then as she got older, my feeling was, and as you listen, you feel free to disagree. My feeling was well, now it's her decision and there's nothing we can do anyway. And I understand that now there is something we can do anyway, but it's still, I hear from people all the time, well, it's not really a prevention, it's a delay. And, and it's not easy and it can be costly, even though there are some insurers and I know there are some companies that will work with you and help with this. But devil's advocate, right? Is this still too hard for a family that says, okay, I have a kid with type 1, I'm going to see it in my other kid. They're not going to be in DKA. Right back to the interview. But first, Diabetes Connections is brought to you by EdgePark. Take control of your diabetes with a broad range of diabetes management supplies from EdgePark. The latest diabetes supplies and continuous glucose monitors from top brands simplify blood sugar management. EdgePark accepts most insurance plans, and Medicare and Medicare Advantage covers certain devices. Plus, EdgePark takes care of the insurance paperwork to make ordering as seamless as possible. Go to diabetes-connections.com and click on the EdgePark logo to learn more about EdgePark's diabetes supplies and CGM devices.
Yeah, I so appreciate that question, Stacey. And I, like you, am deeply embedded in the type 1 diabetes community, made similar decisions as a parent. And I want to respect and really honor people's individual decisions. And that's why our work at Breakthrough T1D is about education and awareness. Let me give you a different perspective on screening from our family's experience. And I can tell you that I have heard this from others as well. As I mentioned, I was screened and my husband was screened and our son participated in this TEDdy study. That study is the environmental determinants of diabetes in the young. And the goal there was to understand what's that environmental trigger that causes some people to progress to a diagnosis of type 1 diabetes and not others who are at a higher genetic risk. So we were all screened and my son was screened 26 times in that study. What came back in the mail for us each time was a negative autoantibody result. And having been through a really young diagnosis with our daughter, his screening gave both him and us confidence that he is very, very unlikely to progress to a diagnosis of type 1 diabetes. And what we also know is if you screen as an adult and get negative autoantibody results, my odds and my husband's odds of progressing to a diagnosis of type 1 diabetes are very, very low. But because we know, Stacey, we know adults can be diagnosed. So we're not out of the woods. We have genetic risk. We have familial risk. For me, getting those results was very reassuring. I think we always focus in families on the 5% of people who come back with a positive result. For us, we were in that 95% who came back with a negative result. And I'll tell you, if somebody told me I have a 95% chance of winning $2 billion, I would be quite happy. So most people are going to hear that they don't have autoantibodies when they screen. Those that do, as you mentioned, now have some options. And again, if they're confirmed, they're going to progress. And I understand that can be deeply anxiety inducing. So what I like about the monitoring guidance, and we need to come back to that, is I think for the very first time, Stacey, in that guidance, we address what's the appropriate education that's required for people. And let me underline this, what psychological support do people need? And how do we talk to them in just routine clinical visits so that we're sure that they're getting that support? And that's what I'm really proud of in this guidance. We had a whole psychological and educational working groups. They stood alone. And that is really important for the question you raised. Thanks for letting me get that whole answer out.
I couldn't have written a better answer. I'm thrilled to hear all of that. And I prove your point by, and I didn't say this in the question, I should have. I was screened before I turned 40 because back in the day, you had to be younger than 40, I think, for one of these trials. And I came back negative, and that was a relief. It was a little guilt-inducing, too, because I felt bad for my kid and I felt okay for me. And I wish I had had some more mental health resources to be able to share that thought, because that's a tough one, right? For us parents, we have enough guilt as it is. That is really good to hear. Let me ask you, too, about when I think about screening, boy, wouldn't it be amazing to get the general population?
Yeah.
Right. I know you all are working on that. Can you give us any update or thoughts on screening the general population for type 1 diabetes?
Yes, absolutely. So, we focused on families initially from a research standpoint because families do have an increased risk because of the familial connection. But what we also know, and this may be the case in your family, Stacey, is that 9 out of 10 times or 8 out of 10 times, depending on where you live on the globe, there's no family history of type 1 diabetes. Most people are the first person. I see you raising your hand versus in your family.
It doesn't work well on a podcast. Sorry.
That's okay. Sorry, listeners. But, most people, their experiences, they are the first person in their family diagnosed, or their child is the first person diagnosed. And a challenge then, as we think about a world without type 1 diabetes and ultimately getting to the goal of prevention and starting with delay, is if we only screen family members, we're missing 9 out of the 10 people who are going to be diagnosed with type 1 diabetes. And so we really need to think about, how do we do that? How do we do that in terms of just logistically? How do we do it in terms of cost? How do we do it in terms of education for people who would participate in this? And how do we do it in terms of psychological well-being? And we can't overwhelm the healthcare system. So we're investing along with others at the Helmsley Charitable Trust and other organizations, NIH, all over the world, other countries, in how do we scale this to a population level, but it's going to happen in a stepwise fashion.
Yeah, that's great to hear. That's great to hear. Can we just take a quick time out from the guidelines? And you've mentioned your story a few times. I would love to just, if you wouldn't mind, tell us about your daughter. We talked about this before the podcast. My kiddo was 23 months. Yours was slightly younger, but there's a big difference between 17 months and an almost 2-year-old. And I'm so sorry that she was diagnosed in DKA. We were spared that, thankfully. I shouldn't say, do you remember? Of course you remember.
Yeah.
What do you share about that?
Yeah, I think, first of all, I'll just say I have permission from my fabulous daughter to share our experience. I am proud to say she just graduated last month from nursing school and is about to take her board exam. And I hope one day comes to work in the type 1 diabetes field, up to her, because, she has to live with it and she needs to consider that. But I think she's pretty extraordinary. And I would have loved to have met her in clinic when she was first diagnosed. I will just say that. So what can I say about a diagnosis at 16 months? I will say this. We took her to the doctor multiple times and were sent home, once on antibiotics, another time because they said, oh, she's just probably viral. She's not feeling well. The person who actually diagnosed my daughter, Stacey, is my mother. My mother is an attorney and she defends school districts. And she had unfortunately settled a case involving a child with DKA. And she said to me, Anastasia, you're going to think this isn't right, but I think your daughter has diabetes. And I said, what's diabetes? I'm embarrassed to say now. This is back in 2002. And I went to that book. It's funny, nobody would go to a book now, but I went to a book called What to Expect the First Year. Some listeners out there may remember it. I'm dating myself. And there was one sentence on type 1 diabetes. It was in the index, and there was one sentence, and it said, type 1 diabetes is characterized by polyphagia, polydipsia, and polyuria. And I'm like, what the heck does it? So I put that book down and I got out a big dictionary and I looked those up. And sure enough, it said extreme hunger, extreme thirst, frequent urination. And I was like, bingo. And we took her in the next day. And again, they said, your daughter's probably too young to have diabetes. And I said, well, why don't you just test her? And they did. And when they came back down, I remember they had sent us down to the lab and we were holding her. And I remember the doctor running to the lab. He literally picked her up out of my arms. He said, follow me. And then they asked us, do you want to take a helicopter or an ambulance across town? Because we need to get you to Children's Hospital. We were in Los Angeles at the time.
Oh my God.
And so every moment of that is seared in my memory. And what frustrates me, I guess, is that we're still seeing high rates of DKA at diagnosis. And so that's why the education you're doing is so important. Know the signs. If your child suddenly starts wetting the bed, if your very young child's diapers are very full, if your kid is telling you they're thirsty all the time and urinating frequently, and especially if they're losing weight, know the signs. Listen to your friends who might be telling you these things. If your kid's feeling anxious, sometimes anxiety is the first thing we pick up on. So that's why this kind of education is really important and why I guess I'm engaged in this work.
The key for my son was the weight loss. Because we caught it very early, but he had still lost 3 pounds in about 2 weeks. And I remember the pediatrician said, this really sounds like type 1 because of all, peeing and drinking. She goes, but like in your case, it's just, they're too young. We've never seen anybody this young. And back when our kids were diagnosed, I think it was less common to see it, at least in the practice where we were. I mean, that's anecdotal. But they had never seen anybody under the age of 2 at this pediatrician's. It was crazy.
Yeah. No, you're right. And type 1, remember, it's only about 5% of diabetes in the United States. It's still relatively rare and even rarer in very young kids. So you're exactly right, Stacey. I mean, I think in defense of our partners in primary care, they may only see it once in their career. But that's why beating the drum around education and again, thinking about what other tools are in our toolkit to prevent DKA at diagnosis. Let's use them all. Let's use them judiciously, but let's use all of them. And screening's one of them. Yeah,
I've talked about Tzield and teplizumab a couple of times here, but those are not the only medications, treatments that Breakthrough T1D is looking at and researching, correct? Can you take us through some more of those, or is that too specific?
I'd be happy to share with you, and I can share a handout. And one of the things we're really working on at Breakthrough T1D is having easily accessible one-page documents that help guide people on how to take action based on the information we're sharing. One of them is a current list of clinical trials that we're funding, that the National Institutes of Health are funding. On this particular flyer, it's only the studies in the US because this is a US audience, but we also have a matching tool on our website where you can find a clinical trial. And it's going to ask you for your zip code, but if you're in Berlin, Germany, and you type in Berlin, Germany, it will find the trials around you in Berlin, Germany, which is pretty cool. So what kinds of things are we thinking about? So one is we've done some work and gotten some great data on a very inexpensive blood pressure medication, a calcium channel blocker called Verapamil. It's a pill. And there was some really great data in the study called Clever that said this protects the insulin-producing cells in the pancreas. It was a study with children. The kids who took the drug had more C-peptide, which is a marker of their ability to produce their own insulin, than the kids who didn't. And they all did really well in the study because they were also wearing automated insulin delivery. Yeah. So we're looking at another drug class, JAK inhibitors. JAK inhibitors are already approved to treat things like juvenile rheumatoid arthritis and autoimmune alopecia. Alopecia is when your hair falls out, and there's an autoimmune form of that. This is another pill. We had some great data out of Australia. And so now TrialNet, funded through the NIH, is conducting a study right now at diagnosis on a JAK inhibitor. Another drug is called antithymocyte globulin, and they're testing a low dose of this drug. So there's been a lot of studies in that, including in Europe and here in the United States. This is also now funded, earlier versions funded by Breakthrough T1D, but now funded by TrialNet. And they're recruiting people in stage 2 type 1 diabetes. So they're recruiting people who don't yet require insulin, who don't have any symptoms. So they need to screen people to participate. And that study goes all the way down to the age of 6. So those are just some of the things we're looking at. There is a lot more on the horizon. I think I saw actually on LinkedIn today at the EASD meeting, they were looking at over a dozen different approaches to protecting the insulin-producing cells. So this is something I think people can be really hopeful about and should be.
That's wonderful to hear. I've already kept you longer than we had planned, and I really appreciate that. But before I let you go, I do have to ask, you didn't know what diabetes was when your daughter was diagnosed. You're now, among many other things, a certified diabetes educator. I mean, you're the list of your accomplishments and your credentials is quite long. And it's just incredible to think about your daughter beginning her own journey in healthcare, wherever that takes her, right? As you said, she may not work in the diabetes field, but there is so much hope on the horizon. I think it's almost easier. The cynic in me is going to come out. It's almost easier to have hope when you are in the newer diagnosed phase. When you get down the road, like you and me, and our kids have been diagnosed for a very long time. I'm not sure what's going to happen for Benny, but I don't want his kids to have type 1. Are you very hopeful for that kind of stuff down the road? Do you let yourself hope for that? Because sometimes I don't know if I can let myself.
I so appreciate that question. And I think science is hard and incremental, and autoimmunity is complex. But I remain imminently hopeful. We had the first backpack automated insulin delivery pump, Dr. Kadish. You've probably seen it in pictures in the 1960s. That's 60-something years ago. And I will tell you, you can look back and see articles that say this will never happen. We'll never get there with this technology. We don't have the mathematics. The insulins are too slow. Lo and behold, we do have a second or third generation of automated insulin delivery systems that are working really well, and people are realizing the benefits. 50 years ago, we could not describe how type 1 diabetes happens. We had no understanding of the early stages that we can now not only describe, like we talked about earlier in this podcast, but there are actually scientists now working in human type 1 diabetes who can show that immune attack on the islets. And in vivo, like in real time, recorded over 17 hours, they can actually show that attack. That's the first step, because once you can see how it happens, then you can think about how do we intervene. So am I hopeful? Yes. Do I know when it will happen? No. What I do know is it will never happen if all of us don't raise our hand and get off the sidelines in whatever way we feel comfortable to make life with type 1 diabetes better. So the way I see that happening, and what gives me agency or allows me to kind of strike back at type 1 diabetes as a parent, is anytime somebody asks me to take part in a study, and I've done all kinds. I've given blood to see if there's something unusual about my immune system as the family member of a person with type 1 diabetes, and I've sat in or laid in an MRI machine for an hour holding my breast so they could get an image of my pancreas to better understand if it looks different than people who don't have a family history of type 1 diabetes. I will participate. Some people may say, boy, everything you just said makes me uncomfortable. That's fine. But maybe there's a study where you can answer a survey to make the clinical experience better. Maybe you can help understand about distress and anxiety with type 1 diabetes. We've got virtual studies that you can link to on our website that you can complete from your couch and tell people about research. What we know, Stacey, is about 0.2% of people during a general clinic visit hear about research. Only 0.2%. On average, doctors tell 5 people a year and nurses tell 2. We need our healthcare professionals to know what studies are recruiting and to just add one sentence to that clinic visit saying, have you thought about research? That's how the science moves forward. And that's why I remain hopeful, and that's why I do the work I do. So thank you for letting me share all of that. I hope that inspires hope in others as well, and they will think about learning more and getting involved.
I love it. Anastasia Albanese-O'Neill, thank you so much for joining me and sharing all of that. I really appreciate it. And I'm inspired by your personal experience and everything you've done. I appreciate that. Thank you so much.
No, thank you for the opportunity to be here. I think I often say to my kids in life, sometimes it's not how you fall down, it's how you get back up. And type 1 diabetes isn't certainly falling down, but I think I am grateful that I've had a lot of mentors that have allowed me to turn this into a positive and to do a job that has meaning. And hey, if you're out there listening and you're thinking about working in type 1 diabetes, come on over. It's a second career for me, and you are welcome. The doors are open, and we need your critical voices. So come on over. Thanks for having me today, Stacey.
You're listening to Diabetes Connections with Stacy Sims.
More information in the show notes, including the guidelines themselves. Thrilled to hear the guidelines include mental health resources, but just met a woman at Mom's Night Out Denver who got her child screened. Her child does not yet have full-blown type 1 diabetes, but they're in the early stages of it. And she was talking about how she feels really all alone. She said she's on an island out there. I'm so thankful she came to Mom's Night Out, and we connected her with a lot of great local resources, mostly the community. So I'm going to be following up on that because it's one thing to hear the plan. It's another thing to kind of see what's happening in action in the real world. So definitely stay tuned for more on that. And hey, that's what Mom's Night Out is all about. I mean, Denver was absolutely amazing. It was our smallest event yet, I'll be honest with you, but it was incredibly impactful. Everybody who came was looking for something. They were looking for resources, connections, babysitters. They were in it. I think maybe because the word is out now about this event, and they came from all over. We had people coming from different states. We had one woman who's planning to move to Denver. She came from very far away. She met babysitter potentials. She met a family that, is going to give her a babysitter. She met another family that they're putting together a play group. This is what it's all about. This is what I wanted to do. So if you're in the Philadelphia area, that is where we are going next. We have more locations coming in 2025. Our first 2025 location is on the website. If you're listening this long, I'm just going to tell you it's Atlanta. And we're very close to announcing our 2025 cities. So please head on over to Mom's Night Out. That's over at diabetes-connections.com and click on the tab. I really want to hear from you. I want to know where you want us to go and how we can make this event even better for you. And yes, women with type 1 are welcome as well. I don't know how we're going to change the marketing for this, but at each event, we have more women with type 1 along with the moms. And it's just amazing. So thank you. Thanks to my editor, John Buchanan from Audio Editing Solutions. Thank you so much for listening. I'm Stacy Sims. I'll see you back here soon. Until then, be kind to yourself.
Diabetes Connections is a production of Stacy Sims Media. All rights reserved, all wrongs avenged.
When you're deciding on a brand of insulin pump, there are a lot of things to think about, especially if you've never used a pump before. It can seem overwhelming. There are a lot of choices, and you want to make the right decision. That's why I'm so excited to tell you about Omnipod 5. Curious about trying an insulin pump or seeing what life without tubes is all about? Unlike traditional tubed pumps, you can try Omnipod without being locked into a 4-year contract. You might even be eligible for a free trial. Go to diabetes-connections.com and click on the Omnipod logo for full safety risk information and free trial terms and conditions. Also visit omnipod.com/diabetesconnections.